Good afternoon. It's my honor to welcome you to today's important discussion, Measles in America, Why Now and What's Next? I'm Candace DeMatteis, Vice President of Policy and Advocacy for the Partnership to Fight Infectious Disease. We're fortunate to be joined today in hosting this event with the Infectious Diseases Society of America, or IDSA. We're all deeply concerned about the resurgence of measles in America, an illness that was deemed eradicated 25 years ago. We're also concerned about potential shifts in policy that threaten to undermine our ability to control measles and other vaccine-preventable illnesses in America. We all know that skepticism is on the rise and vaccination rates are declining. Achieving the eradication of measles was not an accident, though. It was a result of decades of scientific progress, strong public health infrastructure, and an unwavering commitment to vaccination. And yet, here we are, 25 years later, facing outbreaks that could have been prevented. Cases are rising along with vaccination exemptions, misinformation, and untruths that fuel skepticism, and critical public health policies and infrastructure at risk of being weakened when we need them the most. And Americans are concerned. Recent polling that the PFID did showed that 69% of voters in America are concerned about declining childhood vaccination rates. And that poll occurred before the latest measles outbreak. Given the level of interest and the deluge of misinformation downplaying the risks associated with measles, while dialing up rhetoric about the risks of the MMR vaccine that protects against infection, we brought together 3 experts to share the science and medical understanding of measles, vaccination, and what's at stake. We are here to separate fact from fiction, to understand the real risks of complacency, and to discuss what must happen to protect the vulnerable in our communities at large. If at any point during the discussion today you have a question, please send it to us using the Q&A function at the bottom of your screen. We will have time at the end for audience questions, and we'll get to as many as we possibly can. Thank you again for joining us, and I am thrilled to introduce our experts. I'm going to start with Dr. Michael C. Burgess. Prior to being entrusted with representing the people of the 26th District of Texas in the U.S. House of Representatives, Congressman Michael Burgess practiced medicine as an obstetrician for 30 years. Dr. Burgess served on the House Energy and Commerce Committee as the chairman of the Subcommittee on Commerce, Manufacturing and Trade, in addition to sitting on the Subcommittee on Health and the Subcommittee on Oversight and Investigations. Dr. Burgess also founded and co-chaired the Congressional Health Caucus and was a leader in the influential Doctors Caucus as well. His medical background and experience provides him a unique perspective on health policy and legislation affecting healthcare. His commitment to protecting patients' rights and raising the bar of our standard of care can be seen in his efforts to expand care options for patients, to sensibly reform liability laws, to protect patient rights, and to ensure that we're educating enough doctors to provide proper care for civilians and veterans alike. Thank you so much for joining us, Dr. Burgess.
Thank you.
Dr. Jewel Mullen is the founding Associate Dean for Health Equity at Dell Medical School and an Associate Professor in Population Health and Internal Medicine. She also serves as the Director of Health Equity for Ascension, Seton, and Central Health, leading efforts to improve healthcare access. A board-certified internist, epidemiologist, and public health expert, Dr. Mullen previously served as the Principal Deputy Assistant Secretary for Health at the U.S. Department of Health and Human Services and Commissioner of the Connecticut Department of Public Health. She holds degrees from Yale University, Mount Sinai School of Medicine, and Harvard University. Thanks for joining us, Dr. Mullen.
Thank you.
And last but certainly not least, Dr. Tina Tan is Professor of Pediatrics at the Feinberg School of Medicine, Northwestern University, and a pediatric infectious diseases attending physician. She is also the medical director of the International Patient Services Program, the co-director of the Pediatric Travel Medicine Clinic, and the director of the International Adoptee Clinic at Anne and Robert H. Lurie Children's Hospital of Chicago. She is board certified in pediatrics and pediatric infectious diseases. Dr. Tan received her medical degree from Louisiana State University School of Medicine. She completed her residency, chief residency, and pediatric infectious diseases fellowships in the Department of Pediatrics at Baylor College of Medicine in Houston. So lots of Texas connections here today. Dr. Tan also has served as the chairperson of the American Academy of Pediatrics section on infectious diseases and as a member of their Committee on Infectious Diseases. She also serves as a member of the Academy's Global Immunization Advocacy Project Advisory Committee and is a technical advisor for the Academy and CDC's Global Immunization Advocacy Project, the Academy's Antimicrobial Resistance and Stewardship Work Group as well. And last but certainly not least, Dr. Tan is the current president of the Infectious Diseases Society of America, our co-host today. We're honored to have you all with us to help us understand measles in general, what's driving these outbreaks, and what can be done to stop it and avoid it in the future. So I'm going to jump right in with some rapid fire questions because we have a lot of ground to cover. So Dr. Tan, I'm going to start with you. What exactly is measles? And if you could talk about how contagious it is and how it's spread.
So measles is a viral illness that is caused by the measles virus. And it is considered the most highly contagious disease of all the infectious diseases that spreads through direct contact with infectious respiratory droplets via either airborne spread from coughing, sneezing, and talking, or you can also catch measles by touching a surface that an infected person has touched that has infectious respiratory droplets on it, and then you touch it, and then you touch your eyes, your nose, or your mouth, and you infect yourself that way. And a pregnant woman can actually pass measles on to her fetus or her baby during pregnancy, delivery, or while breastfeeding.
That's pretty scary. Dr. Burgess, isn't measles mostly just a rash? We see that a lot. That kind of almost equates it with chickenpox. So what's the big deal if it's just a rash?
Well, in fact, this case of measles gets its start, it's going to look more like an upper respiratory illness. The rash typically comes several days later, but of course, a person is infective not only when they have the upper respiratory symptoms, but probably a day or two before. And that's since, as was pointed out, the virus is so infective and it can be silent right at the very beginning. So in a large unvaccinated population, it just gives so much opportunity for spread. The other part of measles, and we do kind of forget this because, all right, in full disclosure, I was unvaccinated because the vaccine wasn't invented. I'm so old. So in the 1950s, we all got the measles, and I remember it still, even though I was probably 4 or 5 years old. But I remember the hard shaking chills, the muscle aches. The rash was discouraging, but what was more impressive was just how sick you felt from the well, literally from the viremia, from having the virus throughout your system. Now, in some cases, pneumonic complications, pneumonia or pneumonitis from the virus can also be a complicating factor. In my past life, I'm an obstetrician, so one of the things we always worried about with viral illnesses was, could the pregnant woman get a pneumonitis or a pneumonia on top of whatever else was going on, and that could be so hard to treat during pregnancy.
Mm-hmm. Dr. Mullen, how long we heard a little bit about that you can be infectious before you even know you have it. How long does measles last typically? Maybe in a normal case versus a more serious case, and then who's at greatest risk?
Yeah, and I think that's a great question to add to everything that Dr. Burgess just said, because a lot of times when, especially when children are sick, parents and the kids wonder, how long is this going to last? And so we can think about a so-called typical case of measles, and I hope you're hearing that we don't really think of measles as typical because we think of it as such a serious infection. It might last 10 to 14 days, but sometimes we think about something lasting in terms of how long we know there are symptoms. And as we just heard, this infection is doing things before people even know that they're fully sick. For example, you might just think your child has a cold. It might not become more obvious until the rash breaks out, at which point you've already had the chance to be spreading the infection to others. And then even after the rash goes away, if you think measles is just a rash, you don't realize that you can still be spreading the disease to others. And so if that was what people would think of as that so-called typical case, and I won't say there is one because of my own old person experience, then what I would say is once you get to the risk of those other complications, it's really hard to say, because then you're in another realm of the really severe cases of measles that we're worried about.
I mean, the
The
other
highest
thing
risk
too,
people, I'll just add quickly, are children who are babies, children who are not vaccinated yet, pregnant women, and people with low immunity from HIV, cancers, and other conditions that weaken their immune system.
yep, because they can basically shed virus for a very long period of time.
So, Dr. Tan, does it take, when is typically like the incubation period? So, say from exposure to when you first start showing symptoms, how long is that period?
So incubation period usually is around 7 to 14 days, depending upon the viral load that you were exposed to. And that's when symptoms usually would appear. And basically the symptoms start out, as Dr. Burgess said, mostly like an upper respiratory tract infection. They get fever, they get runny nose, they can get cough. One thing that's a little different is that they can get red, watery eyes, so they can get conjunctivitis.
Mm-hmm.
And then basically the rash will develop, about, 4 or 5 days after they've started having these symptoms.
So you raise a good point, Dr. Tan, and Dr. Burgess, I'm going to turn to you. Given that we're in the middle of a pretty nasty flu season, we've got RSV circulating, COVID is still out there. All of these are respiratory viruses. How can you tell if it's measles or something else?
Well, sometimes you simply can't with the initial clinical presentation. So fortunately, there are tests that are available to help differentiate that. But it can look, everything looks like the flu when it first starts. Several years ago, that was the big hazard with the people that were exposed to anthrax. It looked like the flu when it first started. So the poor ER doc who saw the folks at first, he's been seeing a lot of flu. That's what this is. I've seen a lot of it this week. Send you on your way, but missed the most important diagnosis. So testing would be the probably what you would have to fall back on, unless there was just so much illness in the community that you could be very confident of the diagnosis.
I guess that's why they ask vaccination status too, and when there's an outbreak as well. I was curious, we talked about that it's not really normal. It is unusual given that, over the past 25 years, we've seen so few measles outbreaks. Have you seen measles, any of you in your practices before? Or how often do you see it?
So when I was a resident at Baylor, Houston had a major measles outbreak, and I saw a lot of cases there. And then recently here in Chicago, there was a measles outbreak at one of the immigrant centers, because many of the people that had immigrated from the other countries were not vaccinated. And so we saw over 30 cases of measles in children here at Lurie Children's.
Yeah, that was in 2014 when there were a significant number of unaccompanied children coming into Texas from Honduras and El Salvador. The vaccination rates in those countries is significantly lower than anything in the United States. And in fact, I did work with other members of Congress to implement for kids that were taken into by the ORR facilities, that they would just simply be vaccinated. You almost had to do it as a no fault, don't ask any questions, just assume everyone is unvaccinated and vaccinate all the kids. Otherwise, we we were going to be importing trouble into this country. I don't know if that program has continued. A lot of that did fall by the wayside the past couple of years, but it's certainly something to bear in mind. I don't know if that's had an impact on what's happened in West Texas, but with the significant number of people who have been coming into the country without going through the normal channels, it's always a risk out there.
So Dr. Tan, how are we going to stop? I was curious about how are we at the end of this outbreak? Are we just at the very beginning? And how are we going to stop it in future outbreaks?
So basically, it's hard to know if we are, where we are in this outbreak, but we do know that Texas, of the 9 states where they have measles cases, Texas has had the most. There have been 164 cases that have been reported since the, I guess, the beginning of February, and 159 of those have occurred in Texas. And it seems like it's continuing to spread because there are now cases that are occurring in on the border between New Mexico and Texas. And really, the best and the only way to be able to control an outbreak of this magnitude is to vaccinate and to get people protected against measles. And for those individuals who either are too young to be vaccinated or pregnant, or they have an immune compromising condition, if they're exposed to someone with measles, within 6 days, you can give them either intramuscular or intravenous immune globulin to provide them with protection against measles. But vaccination really is the key to controlling the outbreaks.
That's really helpful. Dr. Mullen, I'm sorry.
I want to
Yes,
add
absolutely.
Just a thought, and maybe Dr. Tan or Dr. Burgess would want to also respond to it, because knowing those statistics for Texas and understanding that only a handful of the people who have been diagnosed are not part of the outbreak, and some of those have been, say, people who traveled internationally and came back, but they were not vaccinated. There are a couple of other things that I just wanted to prompt, which, especially when we talk about babies and children at risk, is when you see less and less immunity in the community, it's really important for parents, for example, to talk to their doctors if they are going to travel internationally and think about what they can do to protect their child. Dr. Tan is nodding her head because they might be in the age range that's usually too young or younger than you normally give the measles vaccine. So in addition to stemming the outbreak, we have to think about ways to continue to build protection among those people who are still at risk. But I don't know if my colleagues want to say anything about that.
No, that's a great point to bring up, because the recommendation now is that children between 6 months and 11 months who don't normally get, measles vaccine until 12 months of age, if they're going to be traveling internationally, they are recommended to get a dose of MMR vaccine to protect them. And similar with this outbreak, it is recommended that these younger babies who are too young to have gotten their first measles dose, if they're exposed, be given a dose of the MMR vaccine.
That's really valuable information. I hadn't seen it. Oh, Dr. Burgess, I was going to ask you a question. No, but go ahead and comment and I'll follow up.
Well, communities also can provide a significant amount of help. And we assume that everyone who's unvaccinated is there because they're hesitant. It may be that they just haven't done it. And so making the availability, and we found this in my counties during the coronavirus outbreak, and there were some, they took the whole of Texas Motor Speedway and turned it into a giant vaccination clinic, and people just drove through and rolled their sleeves up and got their inoculation and were on their way. It was an enormously successful program. Now, I don't know that we need anything quite on that order of magnitude, but a vaccination program in the community can be enormously helpful.
No, I completely agree with you, but unfortunately, there are some states where they basically have banned the public health department from holding these mass vaccination campaigns to basically control diseases where there are a lot of cases.
So where can, Dr. Burgess, I wanted to ask you, where can people go to find reliable information and guidance if they're things like, you know, the public health departments aren't given the resources or actually forbidden from holding the mass vaccination clinics? Or where can people go to get information about not just measles vaccines, but vaccines in general?
Well, at the risk of covering up your doctor's office with telephone calls, your doctor is always your best source of information. And I mean, that's what we do all day, is answer the telephone and answer questions from people who are concerned about things. So I would encourage people to start there. And your public health department can provide a significant amount of information. I do know that in Texas, and Dr. Mullen, you may have additional information that I don't have, but the CDC has provided resources to Texas, and they can't just do that. They have to be asked to show up. So it's the state is actively participating in trying to get its arms around this outbreak and has asked for help from the CDC. And again, it's my understanding that help has at least been provided, and I guess it endures for a couple of 3 weeks, and maybe longer if it's necessary.
And that's correct. There was an official request for what's called an EpiAid to come in and help. And to me, that's just another example of how even when there are barriers, doctors and public health professionals come together in an all hands on deck way that really works on behalf of the public. And as a former governmental official, here with another one, I would also say in those circumstances, sometimes communities are reassured because their elected officials are also helping spread important messages of reassurance. And that even strengthens a community response.
Agreed. And you can also go to the American Academy of Pediatrics website. You can go to the Infectious Disease Society of America website. There are basically resources there on vaccines that, you know, you can get information. But I agree with Dr. Burgess. The doctor's office is the first stop.
Yes, and if you don't have a doctor, to remember that you can, because many people don't, to remember that you can call your health department, that there are community health centers. I work with a big community health center here in Austin, who will also take your calls and answer your questions and let you know how they can help you as well.
All great advice. Dr. Tan, safety is one of the big factors that people cite. And when they're talking about safety, they're not talking about the disease. They're talking about the risk of the disease. They're talking about the risk of the vaccine. And there have been, you know, a lot of discussion on social media about autism risk and the like. Can you speak to that? Is there any truth to that? And what does the research say about how safe and effective the MMR vaccine is?
So extensive research and clinical trials have really shown that the MMR vaccine is very safe and very effective. The vaccine is made with a weakened live virus, but it cannot cause the disease. And there is absolutely no association between MMR vaccine or other vaccines and the development of autism. And I know that that is something that is perpetuated on different social media channels, but there is absolutely no association at all between the use of MMR vaccine and the development of autism. Potential side effects of the vaccine are generally very mild, and they include mild pain, redness, and swelling at the injection site, which you're going to get with any injection. You can get some mild fever, some mild rash, and maybe a little bit of swollen glands in your neck. And that only lasts for a couple of days. But basically, the vaccine itself is very safe and extraordinarily effective. And serious adverse events associated with the vaccine are very rare. They occur in less than 1 in 100,000 individuals that get the vaccine. So it is extraordinarily rare. as compared to if you get natural measles disease, where there is a lot of risk for serious adverse reactions.
And Dr. Mullen, unfortunately, I understand that you experienced a bad case of the measles as a child, and that was before the vaccine was available. Do you mind sharing what you experienced?
No, so I was born before 1957. Childhood communicable diseases, as they said back then, ran through families. You know, there are 5 kids in my family, and we had great pediatricians who came to our house when we were sick. And you know, so when I got the measles, everybody just thought I had the measles and would get better like everyone else, except for that I didn't, until remembering the day after still having high fevers and barely being awake, that the last thing I recalled was my father carrying me out of the house, not to wait to an ambulance, to drive me to our county hospital where I could get specialized care, where I was unconscious and really pretty out of it for almost a month getting treated. And so I had severe measles, then complicated by a bacterial infection on top of it. And, you know, I didn't know until my parents told me. And I would always remember that they would be in tears to say, you know, you almost died. And I mention that now because in the same way that we said fact, not fiction, I like to say facts, not fear. So I share the story, not to, you know, scare people, but to say, I'm fortunate to be able to sit here and attest to the fact that measles really is serious. I'm grateful that I had great medical care and recovered. And I also have empathy for people who have lost children to measles, or are maybe even worrying now, because we've heard about 164 cases, but we actually don't even know how all of those children are doing. And so we're talking about an outbreak, but we're also talking about an infection whose impact on families right now might not just be a typical case of the measles. And that's all important to keep in mind when people are asking what they can do and what might happen.
And Dr. Burgess, are there long-term effects potentially? We, you know, say someone has to be hospitalized and recovers, and ideally they're like Dr. Mullen and fully recover. But are there potential long-term effects that people may not necessarily recover from?
Yeah, I actually remember learning about a condition called subacute sclerosing panencephalitis when I was in medical school. And I remember the professor said, don't bother to remember that because you'll never see it, because it was associated with measles, perhaps even a decade before. But the fact of the matter is it can have long-term consequences, and we do need to bear that in mind. And the best prevention, the best we can do is prevent it from ever happening in the first place. So those of us of a certain age, well, we got through our infections as best we could, but you don't have to do that anymore. You can avail yourself of the immunization, and you can prevent all of the potential long-term sequelae or down the road complications that might occur, and certainly the additional morbidity or even mortality that might occur with the acute infection.
Yeah, I mean, other things that can last for a long time is that people can become deaf with measles, they can become blind with measles, they can have long-term neurologic complications, especially if they get measles encephalitis. So, you know, these are long-term effects that aren't going to go away, they're permanent.
Yeah, and a woman who is at risk and develops measles during pregnancy can also have, and I'm here with an OBGYN, so I don't need to I don't need to practice his specialty on this webinar, but it can also have really poor consequences for pregnancy outcomes as well.
Yep.
All very important. So given all that, and you're all physicians, you have decades of experience, what would you tell a nervous parent in West Texas or anywhere else in the US who asks you about whether they should get their child vaccinated? We also have a question from the audience about anyone who needs a booster as an adult. Dr. Tan, you want to start with that?
Sure. So basically, vaccine hesitancy is something that has really grown since the pandemic. And one of the things that you want to do is, first off, you want to talk to the family and see what their concerns are about the vaccine. You want to talk to them about the disease that the vaccine prevents and how that disease can have some severe consequences associated with it that far outweigh any of the risks that are associated with getting the vaccine. And you want to provide them with sound scientific data on the vaccine, its safety, and its very mild side effects. And really, try to explain to them that vaccination is the best way to protect them and their child against getting a disease such as measles.
Yeah, I think the risk benefit analysis, if you just look at the numbers, it's overwhelming in favor of prevent the illness rather than try to live through it.
Correct.
I will say this, though, having just come through the pandemic, what has it been, 5 years ago? And, we all hear the statement, the first casualty in war is the truth. Credibility has suffered, and credibility in the public health space suffered a lot during the coronavirus outbreak. And unfortunately, some of it was self-inflicted. So I think we, particularly as policymakers, as physicians, we need to be careful and to listen to our patients' concerns, our families' concerns. We cannot be dismissive. We can't talk down to them. We've got to try to present the facts as unemotionally as possible. But ultimately, it's going to come down to a person or a mom or dad making their decision for their family. And this is where I think docs can be so helpful in just talking one-on-one with the mother or father or with the patient themselves, and try to provide them that unbiased, unemotional information. But I've seen it on so many different levels. The credibility of public health services that have suffered so much during coronavirus, it's hard now to get that back. You're not going to get that back in just a single effort, but it is going to be a long-term project to try to rebuild that credibility that's been lost.
But
You bring up a great point.
I agree with all that. And I try to start with ask a question before I try to tell people what to do or even assume what it is they need to know. And since we know that confidence in vaccines started declining even before COVID, we know that all of these efforts to sustain and improve vaccination rates have to address a lot of different things that are going on, including the numbers of reasons that people might be uncertain about getting vaccines or just wanting to exercise their own rights, and the degree to which we can meet the individual patient with understanding and empathy and listening, the better. And I try to tell learners a lot, don't hear about or see someone and assume you know how they feel or where they're coming from. Or as I used to put during the COVID pandemic, if you see whatever kind of person walking in the room, don't think they have vaccine hesitancy stamped on their forehead. They might just be still in the process of trying to make the decision for themselves.
Right. And the thing that's really important, and you both brought it up, is that you have to be able to develop a trustful relationship between the physician and the patient. And, as Dr. Mullen said, don't give up on the patient. If they don't accept the recommendation the first time, present it to them the next visit. Because, that's really important for individuals to understand that you really strongly recommend the vaccine because you think that that's the best thing for them or their babies.
And as a doctor, among doctors, I also want to add that we have our own work to do on ourselves to be sure that we are as informed as we ought to be to have those conversations, and to be sure we know the difference between how we care for people with professionalism and where we also check our personal feelings at the door, because it's really tricky sometimes to know how those are operating together in a conversation. But maybe my colleagues want to address that.
No, I mean, we know from multiple studies that the recommendation of a healthcare provider that someone trusts is usually the advice that the person will take. So you bring up a great point. You cannot be judgmental just meeting somebody. You really have to speak to them and try to develop a trustful relationship.
And it's
Dr.
not
Burgess,
static.
did you find that amongst, oh, sorry, yeah, no,
Well, I was
absolutely.
just going to say it's not static. I mean, this situation will change over time. I mean, I hope it gets better, but it could possibly get worse, and people may come back and re-ask a question that they thought in their minds was settled previously, and that's another opportunity to bring it up. But I can't tell you how many times I got frustrated because I would hear people in the government making pronouncements about this is the way it is, it can't be any other way, and then 3 or 4 weeks later that was provably false. And it's like no one ever came back and said, we learned something in the past 3 weeks and we'd like to share that with you. I hope going forward we can remember that these are not static situations, but they're always evolving.
No, it's a
I'm
great
sorry, you
point.
had
I
a
was going to
question
ask
for
you
me.
too. Yes, we talked about how the public, and in our polling, we found that people did really lean in and rely on their personal healthcare provider, and did follow through on the recommendations of their personal healthcare provider for themselves and their family. But I was curious about amongst your colleagues on Capitol Hill, how much sway did you have as a physician, as a member of the Doc Caucus, in terms of helping on health policy issues? Did they lean in? And probably not as much as you would like, but I was just
Yeah,
curious about
right. Not
that.
nearly enough. And the problem again, even in that microcosm, which was the United States Congress in the middle of the pandemic, um, the lack of consistency, the lack of clear and forthright discussion. For example, everyone in the United States House of Representatives was required to wear a mask. No one in the United States Senate was required to wear a mask. We all knew that coronavirus was perhaps more severe in an older population. Well, that's the Senate, right? We're younger in the House, but we all had to wear a mask. And there was no antiviral capacity of the rotunda that prevented the virus from crossing. So it was just that inconsistent flow of information that, quite frankly, turned a lot of people off. Now, our job now as physicians and as individuals in the public health space, we've got to reclaim some of that credibility that unfortunately was literally squandered during the pandemic.
Oh, we've got several questions queued up, and I'm going to turn to those, but I did want to talk a little bit about treatment before we did that. Dr. Tana, is there a cure for measles? And there's some buzz about vitamin A. I wondered if you could address that.
So there is no cure for measles. Treatment is supportive, as there's no licensed antiviral medication to treat the disease. Now, in areas of the world where malnutrition is an issue, people will be deficient in vitamin A, and vitamin A is a component that basically enhances your immune system, so that in people that are deficient, vitamin A will reduce measles mortality. And this is especially in low to middle income resource limited countries, where vitamin A deficiency and malnutrition is very common. In persons that are not malnourished, studies have actually shown that vitamin A really has no effect. And one thing that I think all of us worry a little bit about, as people keep, suggesting that vaccines don't work and that you should take vitamin A, is that there is a risk of vitamin A toxicity. And basically, there are a host of consequences that are associated with vitamin A toxicity, and that includes things like nausea, vomiting, and diarrhea, but you can also get joint pain, bone pain, you can get fatigue, you can get skin changes, and actually in some people, you can also get liver damage, you can get blurred vision, increased intracranial pressure, and in children especially, you can get developmental problems as well as other types of neurologic defects. So it's not safe to just keep giving people more and more vitamin A, because if you develop vitamin A hyper, levels and you get toxicity, you are at risk for some fairly severe consequences from that.
And
So
go ahead, Dr. Burgess.
one of the hazards of a lipid-soluble vitamin. So most of us think in terms of Linus Pauling years ago, where he told us you could take gram quantities of vitamin C, but that's a water-soluble vitamin. So if you get too much, you simply blow it off. But vitamin A, vitamin D, vitamin E are fat-soluble vitamins, and it is possible to overpartake.
And they kind of hang around for a long time.
Now, thank you for clarifying that. I once was on a program with someone talking about, well, it's vitamins, it's healthy, it's natural. And the physician on the panel said, so is rattlesnake venom, but we don't advise people to take that. So that's always stuck with me, is like vitamin C is not the same as vitamin A, and you just got to be careful. And again, talk to a healthcare provider to know the difference.
There you go.
Okay, so I'm going to turn to some of the audience questions. And if you have a question and haven't asked it, please pose it in the chat. Some of these are from media, so I will identify them as media. And if you're not comfortable answering, that's fine. We can follow up separately with them. The first one is from a reporter at USA Today. Are there people who are vaccinated and should be protected but are still getting sick? And why? Are these people in vulnerable groups, like you mentioned, Dr. Tan, about, or Dr. Mullen, about people with HIV, for example? Or is something else going on? And what about a weakened immune system makes these groups so at risk if measles is circulating around them? Who wants to take that?
Well, if you have a weakened immune system, your body is not able to basically fight off an infection that you may have, adequate antibodies for. Your immune system just doesn't function normally. So your antibodies aren't going to function normally. And, it's fairly rare for an individual who has been adequately immunized with 2 doses of MMR vaccine that are appropriately spaced for them to come down with measles.
Right. And the whole purpose of having that 97% effectiveness rate, there will be an occasional person who does still come down with the illness. I don't know that we know the answer to this next question. Is the illness less virulent because they had the vaccination? I would expect that's the case, but then we're all familiar with the discussions during the coronavirus epidemic. I wouldn't be comfortable making that statement. At the same time, with 97% effectiveness, you're likely going to have a handful of cases in an outbreak like this where there's 150 people that have been affected. There likely are going to be 2 or 3 that still come down with the measles in spite of the vaccination.
But vaccine basically works by lessening the severity of the illness. So you're right. I mean, you may not even know that they have measles unless you tested them for it.
Oh, interesting. And there was a question about, and I saw this because candidly, this is my age cohort. For people born before 19, there was like a range. So post, I don't want to get the dates wrong, so I apologize. I think it was 1957 to 1968. So that was back, there was a vaccine available, but it was a 1-dose vaccine. And now they're saying potentially people should get a booster. Are you familiar with any of that? And can you share if you are?
It was a different
Dr.
type of vaccine during that time period. And basically the effective vaccine that we use now was produced after that time period. And so it is recommended that if adults who got this prior vaccine that was not as effective or in a measles outbreak, they should get a dose of the current MMR vaccine to protect themselves.
Great. Thank you for that. And I believe that is on the CDC website with the specific dates, because I don't want anybody relying on my memory for those specific dates. Dr. Tan, I believe you also talked about sometimes when people are diagnosed with measles and there's a window or exposed, they knowingly have been exposed to measles, are unvaccinated, that you will go ahead and vaccinate.
Mhm.
How much protection does that provide? If
That
that's
actually
known.
provides a fair amount, 84% or higher. So basically, if you are exposed to measles and you're unvaccinated and you don't have an immunocompromising condition, and it's been within 72 hours of exposure, you can get an MMR vaccine. If you are a baby under 6 months of age, if you're a pregnant woman, or if you have an immunocompromising condition and you're exposed to measles, within 6 days, you can get either intramuscular or intravenous immune globulin, and that will provide you passive protection against measles.
Another great question we got is that anecdotally, and I've seen it as well, and people have been told not to actually trust their healthcare provider, and there have been some aspersions cast against pediatricians and motivations around vaccination. So what more besides being open to those conversations and respectfully listening can individual health professionals do, or associations can do, to address this hesitancy on a broader basis? Or do we have to do the one-on-one conversations? Is there a bigger opportunity?
Really, the one-on-one conversations are the most effective. The other thing that's important is to provide these individuals with resources and links to scientifically sound information on the vaccines that are being recommended. Because what you really want them to understand is that you have a lot of concern for them, and you want to provide them with the best way of protecting themselves and their families against these potentially serious vaccine preventable diseases. And we know that vaccines are the best tool for doing this across the entire lifespan.
And I always feel as if I'm losing people if I get into a battle about who's the right messenger. So the other thing I try to do, because different people like to get their information in different ways, I encourage people to choose from an array of what I can present as reliable sources that will give factual information for them to choose from and stay consistent there. I also encourage people to double check. I mean, I have learned, just as a consumer of the news, to look for something in more than one place before I believe a headline, just because inaccurate information flies so quickly. And so if I'm going to do that about the weather or what somebody said on any given day, I definitely want to do that when it comes to my health.
Yeah, and we do live in the information age. I mean, when I practiced medicine, people didn't have the ability to go home and run to Google and see if what I said was sound. But still, I encourage people to check with Johns Hopkins is a good website. Mayo Clinic is a good website. I haven't checked Northwestern's website, but I'm sure it's quite functional also, as is Dell's website. But there are, I mean, in this day and age, people have at their disposal so many authoritative sources that they can query.
Yeah, and I would like to add 3 letters, CDC.
Yes,
the CDC still has
absolutely.
a highly reliable, fact-based website. And so I, as a consumer of information, a provider of information, always go there as well.
We've gotten several questions wanting to get your views on what policymakers are saying, and specifically Secretary Kennedy. He's made, there was an op-ed that appeared over the weekend about the measles outbreak and vaccination. It's gotten some positive reviews, some negative reviews, but if there's any comment that you would have about that, anything you commend, anything you would have liked to have seen stronger to your level of comfort?
Well, I was grateful that he did come out with a statement. I mean, look, the hazard in a situation like this is to come off and appear dismissive or that you don't care. And I'm now speaking completely apolitically, but people do care that you care. and you need to demonstrate that. Now, the background of him being skeptical in the past, okay, take that for what it's worth. But if he's coming out today and saying, "Pay attention to this, it's real," and I'm going to help the state of Texas get what they need from the CDC. I mean, that's all positive, and I would accept that as a very real and positive help. Again, as I said earlier, this situation will evolve. I hope it gets better, but it may have the tendency to go the other direction. And I'm no longer in office, but I would encourage people who are or who are in the agencies to pay attention. And people do want to hear from you, but they want to hear that you're being careful with their health.
So I can add something to that, having been a state and federal official and worked with both elected officials at both levels as well. I always appreciated the partnership that I could build with my elected officials, whether they were lawyers, physicians, or school teachers. And part of what I appreciated was their reliance on me to provide them with the information that they needed to communicate to their constituents, and then to also help shape policy along with their teams. My hope would be that there will be an environment in which people like me, people like Drs. Tan and Burgess, can be partners with people who are policymakers and help guide the nuance that's really important so that we all act on behalf of the public's well-being.
And that should be the #1 goal.
Absolutely. Sounds great. So all of you have worn different hats and you've alluded to those. If they're, Dr. Tan, as a pediatrician, as an infectious disease specialist, if there are two things that you wanted people to walk away with from this conversation, or, just what's going on with respect to measles or other infectious diseases, what two things would you want them to walk away with?
I mean, I think the most important thing is that I would like them to walk away with the fact that we as physicians really, our #1 goal is to provide the best care possible for their children. And one of the ways that we do this is by recommending vaccines, which we know are safe and very effective and protective against people getting severe infectious diseases.
Great advice. So Dr. Mullen, I'm going to turn to you as an educator of the future physicians, as well as a former public health official and an internist yourself. What two things would you hope people would walk away with?
Well, maybe I'll start with how we enter our profession with the real commitment to do no harm, and to think about that in the many ways in which we practice, which includes understanding how to benefit our patients rather than erode trust or lead them away from making the right decisions for themselves or the best decisions because we haven't learned the appropriate ways to practice our empathy and our professionalism, and to rely on science and research to guide them. And then the other thing that I would say, because we have learners that come from all different perspectives as well, is that if you don't go into medicine to do politics, go into medicine to care for people and really learn how to communicate and care for individuals, understanding that we live in a very complex world, but the way in which we heal and care for people it should not be guided by anything that's partisan or political or ideologic, but based on everything that they take tests for over and over again and practice for the profession.
Yes, pathogens don't care who you voted for, if you voted at all. So great point. Dr. Burgess, both as a policymaker and a physician, what roles do you see for policymakers, and I'm curious about that, and what two things would you love people to take away from this?
Well, can I just say first off that, well, thanks for this opportunity. And one of the things that really concerns me, if we've got if we're incomplete in our protection against the measles, don't forget about the other M and the R in that vaccine, because they're important also. And as someone who practiced obstetrics and delivered babies for 25 years, congenital rubella is something we never see anymore. And that's because people take the rubella vaccine and don't get the illness. But rubella during pregnancy, particularly in the first trimester of pregnancy, is just god awful, and its results on the developing baby. So the fact that we're having this discussion about, the old term for it was red measles. Don't forget about the 3-day measles, because they're important as well. And just as far as the intersection of policy and where policymakers come down on this, and bear in mind that things do change. And again, that's the one takeaway I have from the years in the pandemic, is that people would come up with all kinds of pronouncements, and then 2 or 3 weeks later, the world would be different. Okay, acknowledge that. Admit we didn't know everything. We were trying to help you when they told you this. But now, with additional information, it seems like a rethink is in order. And the public health community did itself an enormous disservice and lost some credibility. Now it's on every one of us to recapture that. And yes, first do no harm. I certainly agree with that. But I also like the other statement that I learned from the AOA: be worthy to serve the suffering. And part of that worthiness is to meet people where they are. And if they've got concerns about what you're outlining for them, help them understand, number one, why you hold the opinion that you do, and two, leave the door open in case they come back with additional information, or there's new information that has been imparted, or the world has changed. We need to be there to help them at all levels.
Well said. Thank you all so very much. And to your point, we have to meet people where they are and rebuild the trust where it needs to be rebuilt, but also encourage people to lean in on the people that they do trust, and that typically are their personal healthcare providers. So we thank you all so very much, and thanks to the audience for the great questions. One major opportunity I wanted to flag for rebuilding that trust is the quick rescheduling of the Independent Advisory Committee on Immunization Practices that was postponed late last month. It is an independent group of experts that weighs in on different recommendations regarding vaccines. That's really important. It happens 3 times a year, and the February meeting allows for insurance coverage and other items. That informs families and physicians for children heading back to school, as well as people traveling over the summer. We talked about traveling to areas where there are endemic diseases that vaccinations can help to prevent. So it's a really important meeting. Still has not been rescheduled. PFID, IDSA, the American Academy of Pediatrics, and more than 60 other medical and patient leaders have signed a letter urging the swift rescheduling of this important meeting, and reliance on the continued independence and expertise of the members of that committee and their recommendations to, again, help rebuild that trust and the independence and transparency that we need to rebuild that trust. So we, again, thank you to ISA for co-hosting this important discussion with us. Thank you so much to our panelists. We really appreciate you taking the time to join us today and sharing your expertise.
Thank you.
Thank you, Candace.
You.